All right, welcome to my talk on the GLP-1 and GIP receptor agonists. I am a little bit concerned that technology is going to fail me when I do my online presentation, so I'm recording this as a backup. So there is no one else in the room, there's no audience waiting to laugh at my jokes, but we're going to get stuck into some good science, and I appreciate you spending the time with me on this journey. So let's get stuck in. Firstly, just quickly, a little run through of who I am. I'm a doctor of medicine and surgery. I studied at the University of Stellenbosch, did my community service and houseman years, and worked in the state ever since. I'm also a scientist. I did further studies in physiology, biochemistry, genetics, and sports science at the University of Stellenbosch again, where I completed my 3 years BSc. And now I'm essentially a longevity and biohacking enthusiast. There's no real course you can do for that. I did more than read Outlive. If you haven't read Outlive, please do yourself the favor. But yeah, I think the sort of biohacking and longevity field is all really about studying and appraising scientific literature, which is really what this talk is all about. I know you have maybe signed up for entertainment, and it's going to be like 50 odd papers that we're going to appraise together, but I promise I'm going to keep it as entertaining as possible. So please bear with me. All right. The GLP-1 receptor agonists. This really is a step into the future. Before we get stuck in, what are they? Okay, well, they're a peptide, which means it's a chain of amino acids produced in the gut in response to eating food. So a lot of people don't know this, but we actually produce these things naturally. When we exercise, we see GLP-1s going up in the blood. It's minimal. It's like 4 or 5 times raise, whereas when we inject them, it's like 1,000 times raise. So we can't achieve massive elevation through exercise, but anyway, it is a natural compound. They are the ones that we're injecting now are the synthetic versions. So we have replicated this peptide that exists naturally in our stomachs in the lab, and we've basically made an injectable version which is pretty much bioidentical, which our bodies then respond to. There are many types of GLP-1 receptor agonists and GIPs. We're going to be focusing on 2. There's sort of 2 that are making big waves in the literature and I suppose media at the moment. That's Ozempic and Mounjaro, or semaglutide and tirzepatide. So a large amount of this talk is going to be based on those 2 products just because those are the most prevalent currently. They are all injections done into the belly fat. We are in phase 3 clinical trials for an oral one. So that should be out sort of, I would guess, probably first quarter, maybe second quarter next year. But these are literally the tiniest little needles ever, and you really don't feel anything. So people who are scared of injections, it's time to overcome your fear. Yeah, done once a week, very, very easy. What do they look like? All right, I'm sure you can't really see what's going on here, so I'm going to see if I can zoom in a little bit, which I believe. Okay, cool. Let's just zoom in here. All right. What we're currently looking at here is Mounjaro, all right? The molecular structure is fairly complex. It's given here with all of the carbon, hydrogen, nitrogen, oxygen bonds. But if we look at it simplistically, the amino acid chain that is the peptide, all right, is bound to an albumin molecule. And we see normally when we ingest these products, so let's say I were to inject myself with Mounjaro, being this compound here, we have a DPP4, which basically breaks apart this peptide really quickly. So if I were to just take plain Mounjaro, for example, with no albumin, I would have to inject this sort of 3 or 4 times a day to be able to get the results I want, because the body breaks it down really quickly. So what we've done, not me personally, but what scientists have done in the lab is they've added what's called a DPP4 inactivator, so that this breaks down a lot more slowly. So now we only have to inject once a week. They have also added an albumin to the chain to make it slower digestible, if I could put it that way, slower to break down. So now we only have to inject these once a week. If you look at the comparison between Mounjaro and Ozempic, you can see they're very similar compounds, very, very similar. Mounjaro basically having an extra side chain, but Ozempic being very, very similar in nature. Again, we've got the DPP4 inactivators and we've got the albumin. When you look at sort of Ozempic, Mounjaro, Wegovy, all of these things on the black market, so the sort of like order of Alibaba, it actually probably is Ozempic, Mounjaro, Wegovy, as in this chemical structure, but doing this DPP4 inactivation and adding this albumin side chain to make it so long lasting in our systems is actually extremely complex and very expensive. So what they do on the black market is they add other things to be able to achieve the same result, getting this long acting compound for a fraction of the cost. So what we start to see are things like heavy metals being thrown in and other toxins which essentially won't show up in your health for about 10 or 15 years. So you think everything is great, but I highly, highly recommend never going black market route. It's just such a terrible idea. Yeah, cool. That's the sort of nerd chemistry behind this. All right. Let's have a quick look at what tissues are affected by the GIP and GLP-1 agonists. All right, so GLP-1 being Ozempic, GIP being Mounjaro. You can see all of the tissues that they affect. So we've got pancreas, liver, heart, kidney, brain, stomach, gut, testicle, bone. Essentially, there are GLP-1 and GIP receptors all over the body. And when we inject, it has some kind of influence on that tissue. I'm not going to go into this right now, but as the talk goes, you will see that the overwhelming theme is that the GLP-1's binding to these different tissues is overwhelmingly positive for longevity and health. And we'll get into all of that. Yeah, ignore all of this. This is more just to show you all of the tissues that it acts on. All right, what are the side effects? Very importantly, very, very importantly, cancer comes up all the time with my patients. This is something that they bring up. Here's going to be our first paper. So this paper is called Adipose Tissue, a novel target of the incretin axis. And incretin is just a GLP-1 peptide. So you can either call them Ozempic, GLP-1s, incretins. Yeah. Anyway, lots of names for the same thing. Right. In this paper, this was the essential finding that I wanted to go over, and we can ignore the whole thing. What I really want you to understand is how it ends. There is no clear indication of an elevated cancer risk with currently available GLP-1s. This paper appraised all of the literature on all of the different GLP-1s, more than just Ozempic, and could not find a correlation. There was one paper which showed a correlation between Ozempic use and cancer. Very interestingly, this paper found that 7 in 1,000 people who are injecting water, so the control group, would develop cancer, and 8 in 1,000 people injecting Ozempic got cancer. So that was just really poorly done study, and that was just unlucky that the Ozempic group had one more person develop cancer. It wasn't statistically significant, and people have way over reported on that particular paper. Cool. Pancreatitis, this is another one we see. People say, oh, I'm going to get pancreatic cancer. Okay, no, it's pancreatitis. At massive, massive doses, maybe. But from this paper, what we saw at the doses, which are human doses, all right, the risks of either acute pancreatitis or pancreatic cancer with GLP-1 receptor agonist treatment was not significantly different from that of the placebo arm. Very interesting. All right, so no cancer, no pancreatitis, ignore it. And these are the studies, you can go have a look. What we do see, all right, definitely GIT disturbances, nausea, vomiting, constipation, and diarrhea. All right, these are all mild and reduce significantly over time, and most importantly, are dose dependent. This whole talk that I'm about to give is going to be on a new dosing protocol called the microdosing protocol, where we take much less than what has been recommended, and we can avoid literally all of these side effects. All right, another thing that people ask me a lot is, isn't this a lifelong therapy? Well, look, it doesn't have to be. If you do this correctly, you will not regain the weight that you have lost. We'll talk about how to do it correctly. But if you were to want to take this lifelong, I recommend it, man. I think it's awesome. I'll show you what the long-term sort of health benefits are, but let's get into that later. And then there's concerns surrounding the newness of the drug. Isn't it new? We don't know what side effects there are. Yep. Okay, this is 21 years old. We have a lot of data on this. It's really not a new drug at all. It's just new kind of in the media. Okay, the first study we're going to get stuck into. The study here, efficacy of GLP-1 receptor agonists approved for the weight management in patients with or without diabetes. So all of these drugs were developed initially for diabetic patients, and people are saying, well, we shouldn't be using them unless we have diabetes, what. Let's have a look at what the data says for both diabetics and non-diabetics for fat loss specifically. All right, obesity is a problem. This is why we're talking about this. This is why this drug has gotten so much, I want to say, reputation in the last couple of years. If we look at this year, as of Friday, 1st of March, this year, more than 1 billion people currently alive are obese, right? Not overweight, obese. Obesity rates globally have doubled in the last 15 years. That is nuts. And according to current trends, more than half of the world's population will be overweight in 10 years' time. So that is scary. We know obesity is a problem. All right. Why is obesity a problem? Does it just make us feel bad about ourselves to be chunky? No. All right. We can have a look at what's causing death. All right. So I couldn't find the South African stats. They weren't published for last year just yet, but these are the stats for America. Causes of death. Top 10 causes of death. Heart disease, all right, linked to obesity. Cancer, linked to obesity. Unintentional injury, all right, so that's couldn't get out of the way of the car because you were too chunky. Obesity. Stroke, linked to obesity. Chronic lower respiratory disease, linked to obesity. Alzheimer's disease, linked to obesity. Diabetes, obviously, linked to obesity. Kidney disease, linked to obesity. Chronic liver disease, we're going to have a look at this in detail very shortly, linked to obesity. And COVID-19, we know all the people who died were either old or obese. So obesity is an issue. These are the worldwide trends of obesity, right? So this is females, this is males. The reds obviously being a high percentage of obesity in that country. So the reds being kind of like 50%, the blues being sort of lower percentages. I just bring this up to irritate all of my South African women because the men are doing quite well-ish. I mean, it's still like 25% of men are obese in South Africa. The rest of the world tracks, the correlations are quite similar, aside from Middle Africa, where the men are maybe a bit overworked. Fine. The point is, a lot of the world is obese, and predominantly the Western world. So what is going on here? Let's try to figure this out. When we are obese, there are certain things that go wrong. Basically everything goes wrong, but this slide shows us a very basic outline of all of the organs that are affected. So it's liver, cancer, gallbladder, type 2 diabetes, muscles, joints, infertility, kidney failure, skin fold rashes, all right? If you've lost the TV remote, check in the skin folds. Gastric esophageal reflux disease, sleep apnea, depression, and stroke, all right? This is not everything that diabetes causes, but this is what we see very commonly. And we can see, I mean, this is really not where we want to be. So obesity and diabetes, we really need to be moving away from that. Okay, here's how we do it. Here we have the last 18 years of studies. So these are all studies done on the GLP-1 receptor agonists, and we're looking at weight loss. Okay, so the black is a placebo, so that's people injecting themselves with water. Then we've got liraglutide, that's an older GLP-1 agonist, and semaglutide, which is Ozempic, being the white bars. As we can see, weight loss, average weight loss from baseline, when we're taking these peptides, with no change to diet, no change to exercise, but just taking this and living your life, we're seeing tremendously different results. What I will show you is quite a lot of weight loss in the placebo arm here. So placebo effect is powerful. Let's not ignore that. But obviously we can see from this, over the last 18 years, semaglutide or Ozempic has been the #1 performer for losing weight. Very interesting. All right, how does this work? We are going to talk about pancreas, liver, brain, stomach, blah, blah, blah. But in this slide, I'm trying to show us fat specifically. When we inject ourselves with Ozempic, what happens to fat? All right. Through Ozempic's action on the pancreas and the liver, we get improved glycemic control. You can ignore this. This is just explaining the pathophysiology. But we're essentially achieving better glycemic control. That means we have less sugar floating around in our blood, sort of at an average moment. This obviously leads to weight loss, all right. It also binds to the brain to increase satiety. So it binds to the hunger hormones to say, I'm feeling full, I don't need more food. Great. Ozempic also binds to the stomach and slows down gastric emptying. So the food that you do eat stays in the stomach for longer before going through. So you feel fuller for longer. And then, this is where it gets very interesting, the influence on the fat cell itself. All right. One thing that we must quickly just clear up is the fat cell is not just a blob, okay? There is a lot of function in the fat cell. It's actually now classified as an endocrine organ, which means that it produces hormones. Specifically, it produces hormones of inflammation, so we don't want that. All right, so when we take the Ozempic, what we start seeing is an influence on differentiation, which means we have more brown fat than white fat, brown being very good, white being very bad, fat specifically. And then we have stimulation of lipolysis and lipogenesis, which means the breakdown of fat cells, which is amazing, and a decreased lipogenesis, which is the build-up of fat cells. And there's a change in cytokine secretion. So change in cytokine, that just means the inflammatory hormones that the fat cells would normally produce becomes less. And we're going to go into how this works right now. Starting off with the brain, how does Ozempic make the brain less hungry? All right, so I'm trying to diagrammatically show you a very complicated process, but there is an area in the brain, let's call it this box over here, this blue box, and that is called the arcuate nucleus. It resides in the base of the hypothalamus, and it is the center of the brain to control both hunger and emotionality of eating. I'll talk about that shortly. Here, the GLP-1s come and bind to the GLP-1 receptor agonists and cause two effects, right? It stimulates this pathway and it inhibits this pathway. So these hormones produced in the brain cause reduced hunger. These are my feel-good hormones. I've just eaten, I'm feeling stoked, I don't need anything, I'm happy to sit here. These hormones are the hangry hormones. I hate my life, I just want to eat, why do I have all these cravings, feeling depressed, blah, blah, blah. All right, so when Ozempic or Mounjaro binds to this arcuate nucleus in the brain, it causes more of the feel-good and it inhibits your ability to produce the hunger hormones. Great, so this leads to reduced hunger, better energy levels, no food cravings, and an increase in satiety or feeling full. This is where the slide gets very interesting. Prevents overeating, obviously, okay, and then alters food preferences. What we see in patients who start supplementing with Ozempic and tirzepatide is that they actually change what they like. The things that would have been the cravings, the chocolates, the sweets, the chips, alcohol, dairy, you just don't want it anymore. It's just like, yeah, I see that pizza over there, but I would rather have this steak and vegetables, which is obviously going to take a lot of the pressure off dieting. Because to be able to get in good shape, you have to diet, you have to exercise. It just is, okay? We're all human. But it's tedious, you know? So if we can take the tediousness out of this whole process, we can actually start to build really good habits without feeling like we've put so much into it. So this is where this becomes really powerful. Now, looking at the fat cells specifically, just real quick. If we have the GIP binding, so this would be Mounjaro, binding to the GIP receptor, as well as insulin binding to the insulin receptor. So whenever we eat anything, our body produces insulin, more for carbohydrates and for fats and proteins, but whatever we eat, we're going to produce some insulin. And that causes some activity in the fat cell. When we have the GIP bound to the GLP-1 receptor in the presence of insulin, we start to see the fat cell itself become more, if I can say, qualified to do what it's supposed to do and doing less of the things that it's not supposed to do. So we see a lot of lipolytic activity. We see improvements in lipogenesis. The slide is a little bit confusing. They don't mean more lipogenesis. They say improvements in glucose uptake, improvements in free fatty acid uptake, improvements in resistin and osteoponin. So basically, what this slide is showing is even if you stay fat, even if you just power your way through all of the increased satiety that you got previously, and you're like, you know what, I'm not hungry, but I'm going to eat anyway, the fat cell itself becomes less harmful to your health, and you are still insulin sensitive and metabolically healthy, even when you're still obese because of these drugs. If we're looking at the unhealthy person, so without the GIP, we have insulin resistance, we have all of the wrong things happening in the cell, and people develop what's called insulin resistance, which obviously leads to diabetes, and they'll become metabolically unhealthy. So what this slide is showing is it's not only the caloric restriction that's helping. Even without caloric restriction, when you're supplementing with these peptides, we see dramatic improvements in metabolic health. Awesome. How does this happen? This is a very complicated slide. We don't need to know everything here. Basically, here's how it works. On all of these different pathways, we see a decrease in the amount of pro-inflammatory cytokines that are being produced, right? So when we have a dysfunctional fat cell, we see a lot of inflammation, fibrosis, inflammation, decreased differentiation, so we can't form the brown fat cells, which are super healthy. And we see a lot of the adiposity migrating, migrating from the subcutaneous, and we're seeing more visceral fat being built up, all right? And all of this leads to cardiovascular risk. All of these pathways are blocked by the GLP-1s and the GIPs. So the fat cell itself doesn't stay as inflammatory in the body. All right, miracle obesity cure, right. Here is, in layman's term, what this article is trying to say. We're seeing decreased ectopic fat distribution. Ectopic fat just means fat where it is not supposed to be. So we're seeing decrease in that. We're seeing improved metabolic health of fat cells. So even if we have the fat cells, our health improves. There's a direct effect on fat's ability to burn as stored energy. So the Ozempic binds to the fat cell and says, hey, whenever the body needs energy, just release it. So we're seeing a lot of our energy for the day, firstly, improving, and all of that energy coming, or not all, but a large majority of it coming from fat cells. There's decreased inflammation globally, all right? That doesn't mean around the world, it just means all around the body. And visceral fat is influenced to a greater extent than subcutaneous fat. This is a direct quote from the study, all right? Let's read it quickly. Visceral fat is influenced to a greater extent than subcutaneous fat. So the fat around the organs is influenced more than the fat underneath the skin, inferring that GLP-1 therapy gives benefits that caloric restriction alone cannot. So even if you just diet and exercise and restrict and hate your life, you're still not going to get all of the health benefits you would get from the GLP-1 agonists. All right, heart health. Moving on. So we know, okay, it's going to make us leaner and feel better and look better and all of that. Great. Very happy. High five. All of those in general can be achieved through healthy eating and exercise, but supplementing with the GLP-1s make it super easy. The rest of this talk is going to be talking about the longevity of this product. How does this product make us live longer and healthier? All right. So this study, please go and check it out. It's a very cool study. Basically has a look at how does Ozempic affect the heart. Let's go into some detail. Firstly, it stops us from having heart attacks. All right. What is a heart attack? Well, very simply put, it's a blocking of the vessels that feed the heart blood. So our heart pumps blood out to the rest of the body, but some of that blood that it pumps out goes back to feed the actual heart cell, which are what we call the coronary arteries. When they get filled up with plaque, which is general cholesterol and lipids, what we see is a formation of plaque. The plaque ruptures, we get a blood clot, and then this vessel becomes occluded, and we can no longer get blood to the heart to be able to feed the heart muscle, and the heart itself dies. We call that a myocardial infarction or a heart attack. All right. This study, I'm just going to read through a couple of things. Showed, okay, when we see MACE, that means major adverse coronary events, all right? Coronaries being these arteries, like I said, these are the coronary arteries. So major adverse coronary events, all right? So people who are on the GLP-1s showed a reduced cardiovascular death by 13%. So even if you had a heart attack, you had a 13% less chance of dying if you were on Ozempic, and a total reduction in myocardial infarctions by 10%. So you were 10% less likely to get a heart attack. Among the individual trials, so a lot of trials were done, and they were done on all the different types of GLP-1s. The strongest benefit was seen with subcutaneous semaglutide, so injectable Ozempic, which lowered rates of major adverse cardiac events by 26%. That is ridiculous. The magnitude of event reduction with the GLP-1 receptor agonists, especially Ozempic, also compares favorably with the effectiveness of other drugs commonly used to mitigate cardiovascular risk. For example, statins. We're seeing guys who have cholesterol derangement and health issues because of cholesterol do better on the GLP-1s than they're doing on their statins. Phenomenal, all right. And then subcutaneous semaglutide or injectable Ozempic was associated with 35% reduction in revascularization procedures of either the coronary or peripheral vessels. What this means is, if you had a heart attack, the body, if you were on Ozempic, was very quick to heal itself, and they didn't need to go do bypass surgery. They didn't need to put a stent or a balloon in. People were able to heal just on their own with a 35% more effective rate. Here's how this works, all right. If we're looking at the coronary arteries like this, I'm going to zoom in on this plaque and show you what's happening on a biochemical level there. Here's the plaque. Here's where the blood would normally be flowing, all right. So this is a cross section. This is the wall of the artery. Great. We have a lipid core, which eventually grows and grows and grows, ruptures, and then we get a blood clot, and then the vessel becomes occluded. As you can see, there are literally dozens of pathways that influence this from happening. If we supplement with the GLP-1 receptor agonists, they bind to all of these different pathways to decrease inflammation, decrease the risk of rupture, increase plaque stability, increase your ability to vasodilate as you need, and basically stop you from having a heart attack. So what we see is there is a massive decrease in all of the inflammatory pathways and a massive increase in the anti-inflammatory pathways, all right? Very simply put, the more inflammatory you are, the more chance you have of your lipid cores rupturing. By supplementing with Ozempic, you bring all of this inflammation down, and you also let the Ozempic bind to the plaque to increase the stability so it never ruptures and allows for blood vessel formation. Actually, just as a side note, it also brings down total LDL, which is the bad cholesterol, and total triglycerides in the blood, which is sort of the fats floating around in the blood, which is pretty cool. Also brings down blood pressure, as we'll go into further on. All right, heart failure. This is a little bit different. So heart failure is different from heart attack in that there is no blood vessel being blocked. All the heart failure is, it's a condition where your heart can't pump the blood it needs. All right, so heart failure develops when your heart doesn't pump enough blood for your body's needs, and this can happen if your heart can't fill up with enough blood or it can't pump out enough blood. All right, subcutaneous semaglutide or Ozempic is associated with both symptomatic and functional improvement in patients with obesity and heart failure with preserved ejection fraction. So if you haven't lost the ability to pump all of the blood, you have definitely symptoms and you're still struggling to get it out, people improve dramatically with symptomatic experiences when they start supplementing with Ozempic. Furthermore, there was also reductions in systolic blood pressure, C-reactive protein, and N-terminal pro-B type natriuretic peptide, okay, which is a big mouthful to say a biomarker of heart failure. If someone is in heart failure and we draw the blood, we see this biomarker. People who currently have that biomarker in their blood because they are having heart failure, who then start injecting with Ozempic once a week, see a reduction in this biomarker because there's now a reduction in heart failure. Very cool. I'm not going to read through this, but one of the effects we see on the heart is this fat that can go and sit on the heart, which we call visceral fat, which we know is terrible for your health and is associated with heart attacks, decreases when we start supplementing with Ozempic. The reason that we're able to decrease the fat around the heart is because they have a massive amount of GLP-1 receptors. So those receptors are very concentrated here. When we inject with the Ozempic binds to the receptor and allows that fat to be used as energy and melt away. So we see huge improvements with people who have a lot of fat around the heart, who then start injecting with the Ozempic and the fat starts to disappear. Cool. Quickly, just real quick on blood pressure. When you start taking Ozempic, blood pressure goes down. All right. A lot of this information comes from this study. Highly recommend checking it out. We're not going to spend a whole lot of time on here. I'm going to go through 3 quick mechanisms with how blood pressure is brought down by supplementing with Ozempic. The first one, it acts centrally on the brain and spinal cord. All right. In the brain and spinal cord, we have different centers which control either fight or flight. All right. Or rest and digest. Okay, so when we're in a fight and flight or very stressed time of our life, we produce a lot of cytokines that will increase heart rate, cause blood vessels to constrict so that we can improve our blood pressure and stop the kidney from getting rid of water. Because when you need to run away from the lion, it's not the ideal time to need to pee. When you do these effects, increase heart rate, decrease the size of the blood vessels, and retain all of your water, obviously the blood pressure goes up dramatically. When we start supplementing with Ozempic, we see that the sympathetic tone, this fight or flight, observed in the base of the spinal cord, at the base of the brain, is dramatically reduced. The GLP-1s bind to that area to inhibit these pathways, so heart rate stays normal, arteries stay nice and open, and your kidneys stay healthy and excreting urine. Right. Obviously, we need some fight or flight. If there's a lion, we've got to be able to run. It doesn't block it to the extent that you can no longer have a fight or flight response. But the normal stress response of your day, someone cutting you off in traffic, the kid being sick, your dog breaking its leg, whatever it is, the stress of the day is deeply mitigated when you're on these GLP-1s because you don't have that huge sympathetic overtone. Great, all right, blood pressure comes down, easy. It also binds to the smooth muscle within the blood vessel. So this would be a normal blood vessel. This would be a blood vessel where the muscles have contracted and made a very small hole, increasing the blood pressure. and this would be vasodilation, so relaxed muscle. So the Ozempic actually binds, there are GLP-1 receptor agonists, receptors, GLP-1 receptors in the muscle surrounding the blood vessels. And the Ozempic binds to that muscle and says, you can chill, you can open up, we don't need this high blood pressure, we're A-okay. So activation causes smooth muscle to relax. Amazing, bringing down blood pressure. Lastly, the Ozempic binds to the kidney. Now the kidney basically gets rid of water with a lot of toxins and minerals and electrolytes and whatever. Fine. Here's how this works. This blue is all kidney and that goes down to the bladder, all right? All the white in between would be your blood. So we reabsorb some things into the blood that we need and the kidney disposes of things that we don't need. Now you'll see we reabsorb sodium at a lot of these places. Reabsorb sodium, reabsorb sodium, reabsorb sodium. So the sodium doesn't go into the urine. The sodium stays in the blood and raises our blood pressure. Ozempic and Mounjaro bind to these different sites to regulate that we are only absorbing as much sodium as we need and getting rid of the sodium that we don't need. All right. Now, because we don't have so much salt in our blood pressure goes down. Fantastic. Real quick. Some concluding remarks, all right, just in bold. There's direct action on the central nervous system, the brain and spinal cord, as we saw. There's direct action on the blood vessels, and there's direct action on the kidneys. So it's kind of like a tripod way of bringing blood pressure down. Very cool. All right, the liver. This is probably my favorite part of this talk. Everything comes from this paper, not everything, but this paper goes over a lot of things, but I've summarized a couple of other papers into this. Let's have a look. Here's how lifestyle damages your liver. All right, we start with a normal liver, then we get fat deposits all in the liver. The next stage would be this fat, as we said, is very pro-inflammatory, starts to cause these areas of inflammation in the liver. Inflammation leads to fibrosis, and fibrosis leads to cirrhosis. Cirrhosis is basically permanent damage in the liver. That'll need a liver transplant. This will probably need a liver transplant, but maybe it'll just die young. Here, when we're looking at the MASH and MASLD phases, we can reverse this, all right? Here's what causes this whole process to happen. Sedentary behavior, low physical activity, high fat, high sugar diet, all right, fine. We all know that. Altered gut microbiome, so if you don't look after the gut microbiome, this happens. And then genes, can do nothing about genes, fine, all right. Ignore this too much. Basically, what I'm saying is unhealthy diet, too much sugar, too much fat, no exercise. This is what happens to your liver over time. Some people say, you know, it's not going to happen to me. It's happening to you. If you're not exercising and you're not eating well, this is happening. How do the GLP-1s help with liver function? All right, so this represents the peptide. I'm not going to go through all of this, but basically it binds to all of these different organs to elicit a response in each one of these organs. The response that it elicits is an improvement in hepatic insulin sensitivity. So the liver becomes very sensitive to insulin, and then the insulin sensitivity allows it to use sugars for energy, to get rid of toxins, and not store that sugar as fat. Right, we see decreased glucose neogenesis, decreased glycogenolysis, decreased de novo lipogenesis, or the fat cells developing in the liver, and decrease in VLDL, which is the bad cholesterol production. So VLDL, the bad cholesterol, is often produced in the liver, right? And we see a decrease in production there. And all of that leads to a decrease in inflammation in the liver, all right? So the inflammation would be this. These are red areas starting to form in the liver. We have a decrease in inflammation. We have a decrease in steatosis, that's the fat cells, right? So we have a decrease in these fat cells forming in the liver. And lastly, we have an improvement in the MASLD and MASH resolution. Fine. What is that? All right. That is the ability to move from here, back to here, back to here. So if you've really been screwing it up with your life, fine, whatever, now you're here, and you start injecting Ozempic and tirzepatide, what we start to see is a regression of liver tissue back to here and back to here. In fact, one article said this: GLP-1 receptor agonists have been shown to result in high proportions of MASH resolution and are recommended as first-line therapy for biopsy-proven MASH. What is MASH? So this phase here. All right, so if we have biopsy-proven, so someone's gone in with a needle and taken some of that tissue out and looked at it under a microscope and seen all of this going on in the tissue, The Ozempic and Mounjaro is now the first line therapy, which means we don't have a better drug to improve liver function, even in the absence of type 2 diabetes. Right, amazing. From that article, go and check it out. Muscle, all right. This is the study that I cited most commonly, but there's a lot of studies in here. Let's quickly talk about why muscle health is super important, okay? Basically, any disease that you have, doesn't matter what it is. Imagine a disease, Alzheimer's, Parkinson's, cancer, diabetes, infection, doesn't matter. All diseases are improved if you have more muscle mass. So the more muscle mass you have, the outcome of the disease on your body is always better. That is the only thing we know in our whole body that we know has an all-cause reduction in risk. So muscle is super important. Muscle has an endocrine function, right? It's not just to be able to move your bones around. It actually produces hormones, and those hormones are very important with staving off things like Alzheimer's, Parkinson's, cognitive degeneration, all of these things. Fall risk, all right. The number one predictor of end of life is a hip fracture. So old people fall, they get a hip fracture, and that's the beginning of the end, right? If they have more muscle mass, specifically in their legs, they have a decreased fall risk and thus don't die as early. All right, cognitive health, like I said, muscle forms an endocrine function, which improves our ability to think and also decreases rates of depression and anxiety. And also, it is an independent factor of longevity. All of this aside, people with more muscle mass just live longer. We don't know why, it just is. All right, now, muscle loss is a major concern in the prediction of lifespan and health span. I'm going to show you very soon why that is. Let's have a look at causes of muscle loss. All right, ovarian cancer causes muscle loss. Head and neck cancer causes muscle loss. Rheumatoid arthritis causes muscle loss, very bad. Esophageal cancer, very bad. Oh, Mounjaro, it's looking pretty bad. Okay, fine. More cancer causes muscle loss. And then Ozempic causes the most muscle loss. So, all right, here we finally get to the third drawback of these beautiful, beautiful compounds. Okay, so we know there is a high risk of excessive muscle loss when using the GLP-1 and GIP agonists. Let's have a look at what that means. So just to quickly point out, I'm going to zoom in on this here. This study, as you can see over here, was done in 2024. Okay, very recent study by the American Diabetes Association. I'm going to zoom in even a little bit more that we can all see what's going on here. All right, fine. Let's have a look at muscle mass and fat mass. Let's say this was me, okay? I was 50% muscle and I was 50% fat, right? Roundabout. This is an average of a lot of people over a 72-week trial on Mounjaro, all right? When we took the Mounjaro, we see a massive improvement in muscle mass. All of a sudden now I'm 60% muscle mass and only 40% fat. Amazing, everyone celebrates. However, this is a relative change, so this is a percentage. Let's say I weigh 100, I was 50 kilograms of muscle and 50 kilograms of fat. Now let's say I weigh 50. Obviously not, but I've had a reduction in weight. A lot of that has come from fat, but a lot of it has also come from muscle. So even though it appears that we are gaining muscle, we are not, all right? These are relative changes. If we look at absolute change, we see muscle mass has come down 6 kilograms and fat mass has come down 17 kilograms. So the reason it looks like I'm gaining muscle is just because I have lost so much more fat than muscle. So I've lost a lot of fat, but I've also lost a lot of muscle. All right, good. So on average, we decrease about 6 kilograms in muscle bulk over 72 weeks. Why is this the problem? Let me show you this. Here we have a little exclamation mark, all right? Warning. Incretin therapy can be associated with a significant 10% or 6 kilogram loss. So on average, 6 kilogram is a 10% loss, okay, for a 60 kilogram person, equating to a decade of human aging. So what this means is 10% muscle loss equates to 10 years of aging, and we live much shorter. So this is extremely important for us to focus on. Fortunately, that's not permanent. If you stop and you start gymming and you start whatever you want and you start gaining that muscle mass back, your lifespan will then improve again. So it's not lost forever.
Right, let's have a look at a couple of things that the study found. We're still in this 2024 study from the American Diabetes Association. All right, having a look here. We're having a look at people who only took incretins, like Ozempic and Mounjaro, and people who took incretins and did resistance exercise, so a little bit of gym work, all right, over a 70-week period and then 120 weeks. The orange is the people who exercised while on the Mounjaro, right, so they actually didn't lose as much weight, even though they were exercising. And the people who only took the incretin therapies lost a lot of weight, right? But look at the regain. 60% of that weight was regained at the 120-week mark, and the trend was still upwards. So if we had just gone 140 weeks, 160 weeks, we would have seen all the weight come back. In comparison, there's only a 10% regain in the people who did resistance training. Why is that? This study found the changes in fat mass and muscle mass were dramatically different when we were exercising. So here, the blue being incretins only, all right, Ozempic only, had a massive regain. The yellows, who were resistance training, had a very small regain, so the regain is very gradual. And a lot of that weight gain is muscle mass. So we actually see an improvement in muscle mass in people who are training and who are taking the Ozempic, versus people who are not training had a 13% muscle loss, which we know is a little bit more than a decade off your life. So we can mitigate a lot of the risks of losing muscle mass by just doing a little bit of gym, and it doesn't have to be crazy. All right, fine. Very cool, let's move on. This is a slide showing us resistance training versus caloric restriction. All right, let's quickly have a look here. We can go through this real quickly. The orange is caloric restriction. So now this has nothing to do with Ozempic. This is just the average person who's going to gym and restricting their calories. All right. This is a change in kilograms. So people who gym and restrict calories don't have as much weight loss as people who don't gym and restrict calories. The reason is because they're gymming, they're gaining a little bit of muscle. All right. But fat loss is more in the group. All right. And they gain a little bit of muscle. The people who are only dieting and not gymming obviously lose fat, but also lose muscle. So we know without any incretins, we're expecting about a 5% improvement in muscle mass, okay? No Ozempic, this is just diet and training, about a 5%. And we can see that without training and just dieting, we've got a little bit of muscle loss, right? But I want you to focus on this 5% gain in lean mass. Right? That's normal, that's got no incretins, that's just a person doing their gym. Here's what we see in the incretin group. Body mass comes down a lot, all right, fine. Fat mass comes down a lot, lean mass comes down a lot. The blue is the Ozempic, right? The green is exercise, no Ozempic. The orange is exercise and Ozempic, all right? Bearing in mind, if you were doing none of these things, you would have a 5% improvement in muscle mass if you were training without Ozempic. All right, great. Body mass came down dramatically in the training group. Body mass went up in the people who were only training and not taking Ozempic, and body mass came down a little bit for the Ozempic only. How much of that was fat? A lot of it was fat, right? Great. But when we were doing the Ozempic and the training, we more than doubled the amount of fat-specific loss. So it basically turns you into a fat-burning machine. And when you are training, you burn so much more fat than you would ordinarily. So this is how much fat you would burn without any Ozempic, but you're still training, right? It's almost 4 times as much when you just inject once a week. So it's a bit of a cheat code there. And if you're only injecting, you get about half the benefits. But have a look at this. Lean mass in the Ozempic and exercise group improved 5%. So it tracks on what we would see if you're just caloric restricting and training. It doesn't mean that Ozempic itself is making you lose muscle. It's the caloric restriction and no training that we see causing muscle loss. So you can mitigate lean muscle loss entirely by taking your Ozempic at the right doses, the microdosing protocol, not the normal protocol that's being prescribed so widely in medicine, and putting in some kind of resistance training in your day. And this is not like crazy training. This is like 2 or 3 times a week going to the gym. How does it do it? All right, how does it help with muscle mass? It's extremely complicated, all right? And you can screenshot this and kind of figure this out for yourself. But basically, what it does on a very basic level, it puts more mitochondria into the muscles, all right? So we get more mitochondria in the muscles, we can produce more energy. There are more blood flow now to the muscle because it looks after the tiny little blood vessels like we showed earlier. They don't become inflamed and blood flow is better. We have an improvement in the muscle's ability to use glucose and fats for energy. And we have a lot of a decrease in the things that cause inflammation. So we have a lot of anti-inflammation, and that insulin resistance becomes pretty much non-existent. All of these effects allow us to use energy and oxygen much more efficiently, that the fibers become a lot better trained to do what they're supposed to do. Amazing. So the conclusion, we don't need to go through all of this, but what we can see is that GLP and GIP agonists are an incredibly powerful tool to alter body composition. It basically helps you burn 4 times more fat. When done correctly, that is the most important thing. The microdosing protocol is everything here. All right, caution needs to be taken with dosing protocols, dietary advice, and exercise advice. There is a wrong way to do these therapies. That is super, super important. All right, and this is a study which showing that based on the evidence we've got, muscle mass gain and muscle mass loss tracks very similarly, like I've shown you, with whether you're on the treatment or not. It doesn't lead to muscle loss as long as you're controlling for protein and you're also controlling for exercise. Amazing. The last thing I want to talk about is neuroprotection. All right, specifically Alzheimer's and Parkinson's. 2 studies that I'll cite here. There are sort of a million studies you can go and have a look, but these 2 are really good if you want to go check them out. Before we can get into this, we just need to talk about the brain cell types. All right, there are many brain cell types. We're going to speak about 2. We're going to speak about neurons, and we're going to speak about microglia. All right. Neurons are these big cells. They're the information highways in the brain. They allow me to see something and then understand that what I'm seeing, let's say I see an apple, I'll understand that that's an apple because the visual cortex and the association cortex were communicating through axons. So they are the information highways. They communicate information. The microglia are very interesting. They're these little ones, and they are existing in between the neurons, right? So they're in between the neurons chilling there. And they basically are the primary immune cells of the brain. They respond to pathogens or infection and injury by changing their shape, migrating to the site of infection or injury, where they destroy the infection and remove the damaged tissue from the injury. All right. In adulthood, microglia are important effectors of plasticity. So our ability to keep learning relies very heavily on the health of the microglia. All right, contributing to neuronal circuit maintenance, all right, as we know, it maintains the circuit, and remodeling. So if we need to remodel areas of the brain, it's controlled by the microglia. All right, as well as learning and memory, and the adaptation to an enriched or stressful environment. So our ability to deal with learning, our ability to deal with stress, our ability to deal with anything is very closely linked to the microglia. All right, this is how the GLP-1s improve brain health in the presence of an insult, so either an injury or an infection. All right, so here's the microglia. All right, we get some kind of infection, whatever it is. Could be oxidative stress, injury, infection, hyperglycemia, amyloid. That's basically Alzheimer's. All right, then what we'd see is microglial activation. They become activated. They become angry. All right, they produce all of these pro-inflammatory cytokines. All of those inflammatory factors go to the neuron, the information highway, and cause it to die. The death of that neuron further ignites more pro-inflammatory cytokines, which activates more microglia, and we get this progressive disease. That's why Parkinson's gets worse over time and Alzheimer's gets worse over time, because these things just kind of like egg each other on. All right, what do the incretins do? Fascinatingly, they block all of these little pathways where we would get activation of the wrong things. So it brings down the inflammation, it brings down the cell death, it brings down the activation of these microglia. Not entirely. So if you do get an infection, you can still fight the infection, but this like hyper response, which leads to more and more damage, is blocked. Phenomenal. That's the microglia. That's in the presence of an injury. What if there was no injury? What if we're just healthy, happy people and we're injecting with Ozempic? Well, we still see massive benefits, right? Antioxidative effects. So it's a strong antioxidant. Anti-apoptotic. Apoptotic basically means cell death. So it stops your cells from dying and the cells live longer, and thus you live longer. Neurotropic. That means it builds up. It causes more neurons to be developed. Also anti-inflammatory in that pathway. Basically, anti-inflammatory and antioxidative and anti-apoptotic show up a lot, right? So improves the generation of cells, decreases cell death, brings down inflammation, and brings down oxidation. Phenomenal, right? Even in a healthy brain, that's beneficial. Cool. A direct quote from the study says, in the human central nervous system, the brain and spinal cord, GLP-1s have the potential to enact insulinotropic or building up, neuroprotective, anti-apoptotic, antioxidative, and anti-inflammatory benefits. This pleiotropic mechanisms means there are many mechanisms, as I've shown you, as how it does this, but this affords us anti-neurodegenerative protections. It protects our brain from neurodegeneration, like Parkinson's and Alzheimer's. What does this mean practically? All right. Basically, when we're on it, we can delay and possibly even prevent the onset of Alzheimer's and Parkinson's disease. We improve motor function in people who already have them. So if you have Parkinson's disease or Alzheimer's and when you start supplementing with the GLP-1s, we see motor functions improve dramatically. We have better outcomes in strokes. So if you have a stroke, your predictive outcomes are much better. And also a 17% risk reduction. So you're 17% less likely to have a stroke. It's protective in epilepsy, and it improves brain health and cognitive function in all users, even if you have no disease. All right, we're coming to the end of our talk. Here's the take-home messages. Firstly, the GLP-1 receptor agonists clearly have their place in longevity. If we're looking to biohack our way into massive long-term health, we need to take note of these things. While all interventions come with a risk-to-benefit ratio, there is substantial evidence that the GLP-1 receptor agonists have multiple benefits in long-term health and wellness. I think that's very evident. I didn't go into the mental wellness side of things and pancreatic function and immunological function. There's so many others. So it has its place. Okay, dose matters. When dosed too high, or the commonly seen doses that most doctors are prescribing at, most of these benefits are actually lost because we're in a toxic environment. And most of the side effects become present. So all of the side effects we spoke about that do occur, those will show up at high doses. Long-term health should never be sacrificed for speedy weight loss. The truth of the matter is, if you just take a ton of these supplements, you are going to lose a tremendous amount of weight. Yes, you can lose 30 kilograms in 20 days. Absolutely you can. It is that powerful. But that is super unhealthy. And a lot of that weight is going to come from muscle loss, which is going to be a net negative in your overall health. Okay, lifestyle modifications, right? Diet and resistance training are the hallmark of being able to maintain the benefits when the treatments are discontinued. If you are going to go on these, you have to look long term and say, eventually I'm going to want to come off, potentially. And when I do, I don't want to just go back to my old habits. You need to use the incretins to be able to form good habits that when you stop, that is just your norm. That's just the way you live your life. The diet is there, the exercise is there, the sleep is there. All of those things are already there that you can continue to maintain the body that you've now achieved and the health that you've gained along with it. And that's that. When I do the live talks, we have question and answers. And if you can attend the online, I will stay for an extra hour to be doing questions and answers with whoever's willing to ask. But also, if you have any questions and answers, please give me a call. You've got my number. You're very welcome to give me a call or drop me a WhatsApp and be like, hey, what's up? I disagree with this. Or what about this? What do you think about this? I watched a TikTok video on this. Please, all of the information that you can bring is beneficial. And let's bring science back to people in a way that can really help them. Cool. I hope you've enjoyed this talk as much as I've enjoyed putting it together and giving it. And I look forward to hearing from all of you.